Welcome to the recent approvals episode of the Asker University Weekly Podcast. My name is Jonathan Strosberg. I'm Section Chief of the Neuroendocrine Tumor Division at the Moffitt Cancer Center. Today we will discuss approval of Lutetium-177 dotatate for the treatment of patients with advanced somatostatin receptor-positive gastroenteropancreatic neuroendocrine tumors. As a background to today's discussion, it's important to recognize that most well-differentiated neuroendocrine tumors express high levels of somatostatin receptors. Somatostatin analogs bind to these receptors and can inhibit hormone production as well as tumor growth. Radiolabeled somatostatin analog therapy, a type of treatment also known as peptide receptor radiotherapy, or PRRT, represents a means of delivering systemic radiation to neuroendocrine tumors in a targeted fashion. There have been several generations of radiolabeled somatostatin analogs developed over the past 2 decades. The isotope with the most favorable therapeutic index is Lutetium-177, a beta-emitting radionuclide with a particle range of roughly 2 millimeters. When attached to octreottate, a peptide that's similar to octreotide, using the chelating molecule DOTA, Lutetium-177 dotatate binds to the somatostatin receptor, is internalized in the cell and delivers radiation to surrounding tumor cells. Until recently, clinical data on use of Lutetium-177 dotatate derived primarily from large institutional registries, showing objective response rates ranging from roughly 30% in midgut neuroendocrine tumors to roughly 50% in pancreatic neuroendocrine tumors, and median PFS durations of approximately 30 months. Randomized Phase 3 data was generated by the NETTER-1 study, a prospective international randomized trial investigating Lutetium-177 dotatate compared to high-dose octreotide in patients with progressive midgut neuroendocrine tumors. On January 26 of 2018, Lutetium-177 dotatate was approved by the FDA for treatment of somatostatin receptor-expressing gastroenteropancreatic neuroendocrine tumors of foregut, midgut, and hindgut origin. The approval of Lutetium-177 dotatate was based predominantly on studies of the Phase 3 NETTER-1 study. In this randomized study, patients with midgut neuroendocrine tumors progresses on standard doses of octreotide LAR and with evidence of somatostatin receptor expression on octreoscan were randomized to receive either investigational treatment with lutetium dotatate administered at a dose of 200 millicuries every 8 weeks for 4 treatments, followed by standard dose octreotide, or treatment with high-dose octreotide, 60 milligrams every 4 weeks. Primary endpoint was progression-free survival by central blinded radiology review. Secondary endpoints included overall survival, objective response rate, and quality of life. The trial met its primary endpoint with a 79% improvement in PFS. Median PFS was 8.4 months with high-dose octreotide, and had not been reached with lutetium dotatate at the time of primary endpoint analysis. The result was highly statistically significant. At the time of this analysis, the hazard ratio for overall survival was 0.4, with nearly twice as many deaths on the control arm versus the investigational arm of the study. The OS results are still preliminary and need to be confirmed on mature analysis expected in several years. Objective response rate was 18%, with Lutetium-177 dotatate versus 3% with high-dose octreotide. Quality of life analysis showed substantial delay in time to deterioration of quality of life with lutetium dotatate in important domains such as global health, physical functioning, role functioning, diarrhea, fatigue, and pain. The main side effect of lutetium dotatate was nausea and vomiting. This side effect was primarily attributable to commercial amino acid formulations infused before and after lutetium dotatate to reduce nephrotoxicity. Compounded amino acid formulations containing only arginine and lysine can be used in practice and are much better tolerated. Other toxicities included neutropenia and thrombocytopenia, although grade 3 rates of these cytopenias were only reported in 1 and 2% of patients respectively. Lymphopenia is a much more common toxicity but is not clinically significant. We know from large institutional registries with long-term follow-up that rates of acute leukemia or myelodysplastic syndrome are approximately 2 to 2.5%. This represents the most severe toxicity associated with lutetium dotatate. The approval of lutetium dotatate represents a major milestone in the treatment of well-differentiated neuroendocrine tumors. For patients with disease progressing on first-line somatostatin analogs, treatment options are limited. Liver-directed therapies such as hepatic arterial embolization can be used in patients with liver-dominant tumors, although prospective data is very scarce. Everolimus and sunitinib are approved for pancreatic neuroendocrine tumors and are associated with median progression-free survival of roughly 11 months and low response rates. Everolimus is also approved for treatment of non-functional neuroendocrine tumors of GI and lung origin, but activity in typical midgut neuroendocrine tumors appears to be modest. Lutetium dotatate appears to compare quite favorably with other systemic treatment options in terms of response rates, PFS, and quality of life. However, randomized studies comparing active treatment options are needed to help guide therapeutic decisions. Thank you for listening to this week's episode of the ASCO University Weekly Podcast. For more information on peptide receptor radiotherapy for neuroendocrine tumors, visit the Comprehensive E-Learning Center at university.asco.org.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.